Okay, thank you. The coffee break is coming up soon. I will also talk about multiligament injury, and this will not be a comprehensive review of that. It's impossible to do in 10 minutes. So I will just talk about a few basics, and I would like to show you my technique of a posterolateral reconstruction. Just to get an idea of how it looks in Sweden, Sweden is a small country. We don't have that many patients. This is the patients in our registry, mostly men, mean age 27. Football is the most common reason for ACL reconstruction, but very few of those patients have multiligaments injuries. It's more common in more high-impact sports like in ice hockey, rugby, wrestling, and also very common with traffic injuries. So it's high energy trauma, and when you see these patients, the ATLS principles applies. And it's important to remember that knee dislocations are frequently reduced before they come to the emergency department, and many of our patients come late after the injury from rural areas in Sweden, and the injury was missed at the beginning. It's also important to remember that it's common to have peroneal nerve injuries, and many of these are also associated with injuries to the popliteal artery. And due to the artery, it was very important to check the foot pulses and skin color, not only the first day at the emergency department, since they can have intimal tears, and the injury will not be obvious until perhaps after 2 days. So what about single stage? There are a few studies that have looked at single stage or stage reconstruction, and not big numbers of patients, but they have showed that single stage surgery has good outcome, and also that if you do a stage procedure, there is a risk that you will increase the force of the other ligaments. So for example, if you do the PCL and don't reconstruct the posterolateral corner, there will be increased strain on the PCL graft with risk of graft failure. So stage reconstruction can potentially alter joint kinematics and increase the risk of graft failure. So when you do the decision making of a multiligament injured knee, there are some evidence that early operative treatments use improved functional clinical outcomes compared with non-operative treatment or delayed surgery. So with this taken into mind, we try to do surgery early, and we try to do it as a single-stage procedure, if tolerated by the patient. But as I said, many of our patients come late after the injury, so the vast majority is actually done after 6 weeks or more. And then we do it when we have as good as possible function. Another question you should ask yourself is whether you can repair or reconstruct the injury. There are some evidence in the literature that supports that you have higher failure rates if you repair the cruciate or posterolateral injuries. So you should probably not do that. And repair should only be considered for the MCL injuries or occasionally if you have bony avulsions. What about surgical planning? It's highly individualized, so it's really difficult for me to tell exactly how I do it. Depends on a combination of injuries, the ability of grafts that you have. I generally try to avoid harvest grafts from the contralateral side. And I also avoid using tourniquet during surgery. It's prolonged surgery, and you also have a risk of these intimal artery injuries. Some short descriptions of the surgical technique. The ACL, that's a standard anatomic single-banded surgery. With PCL, I have a slightly different view on that compared to Neil. We try to do double bundle quite often. I must agree that it's probably not a complete 100% consensus on that it's better. But there are some evidence, especially from the Laprade group, that says that you get better biomechanics And they also say that you get better subjective outcome if you do a double bundle. But with that said, this is prolonged surgery. It's sometimes very complicated. You have to drill a lot of tunnels. Sometimes, or quite often, I get tired and I don't do double bundle. It's too much. So if it's too much, do single bundle. And also in contrary to Neil, I almost always do the surgery with a quad tendon and I use a bone block, and I almost always put the bone block in femur. But I don't pull the bone block through tibia. I pull the tendon retrograde through the joint so that I have a bone block in the joint and then up in femur. So it never goes through the tibial tunnel. It's possible, but it might be difficult to get it to turn around the corner. The surgical technique for the MCL is based also on the studies of Laprade. The Laprade studies are excellent. It's probably not 100% correct, but it's the best that we have. So I do anatomic reconstruct according to Laprade in most cases, if it's not possible to do a repair. And then if we go to the posterolateral corner, Laprade has done very excellent studies on that as well. And I use the anatomic studies for my reconstruction, but I do it a little bit differently. In the Laprade studies, they have two allografts. And I don't like to use allografts there, because this is a structure that needs to be very stiff, and allografts might have a tendency towards being a bit slack. So I want this to be very stiff. So I try to use the autograft of semitendinosus, and then I use only one graft. And it looks a bit like this. So I take one graft of semi-T, and I have whip stitches of ultrabraid on each side. And in that whip stitch, I also take two ultra tapes that I use as some kind of internal brace construct on that side. It will be difficult to show you exactly the technique, but I've done a small video just to highlight some points. First, you identify the landmarks, of course. It's very important to identify the peroneus nerve at the fibula neck. I won't show you the dissection, but I use most often these guides from Smith & Nephew. But it's possible to do that on freehand as well. We only have one set of these guides, and it's not always available for me. And when I do it in freehand, that's possible as well. Let's hope this video works. I'm always a bit nervous about that. So I start with putting the graft in the LCL tunnel in femur. That's the first thing. And then I take it under the tractus through tibia. Hopefully we can see that. So the next step is to pull it through tibia like this, from fibula. This is the part that differs from the Laprade description. I take this loop. Here it's an ultra button from Smith & Nephew, and I pull that loop through my tibial tunnel, like this. So the tendon goes then through the tibia tunnel, like that. And then I can tighten it really hard. And I put this button on. And you can see here that I have, let's see if I can use this one. Okay. You can see that I tighten it with those, but my internal brace is just hanging here now. So I don't tighten the internal brace. Like that. And I will tighten it more later on. And then I put it intra-articular up so that we have the popliteus function as well. And I fix it first in femur with this bias screw. Here I don't have any tension, so the position of the knee doesn't matter. And the next step is sorry, you have to see this down. Yeah, take it quickly. repetition is the mother of knowledge. Yeah, I fix it first in femur, and then I don't need to, the position of the knee doesn't matter. And the next step is to fix it in fibula, and then I need to have a knee in about 30-40 degrees of flexion, according to biomechanical studies. So I fix the LCL first. Here we go. So here I fix the LCL. Should have, it's a bit too much flexion here. Should have about 30-40 degrees of flexion. So now the LCL is fixed, and then the last step is to tighten the ultra button over my extender button. So I do that now. This should be done in about 50 degrees of flexion. And after that, now the construct is really stiff, and then I just suture the internal brace over it. So the internal brace will probably not be the primary stabilizer. That's the idea, at least. Yeah, what's the sequence of surgery? In many studies, they say that you should start with open surgery, but I always start with arthroscopy, because I'm an arthroscopic surgeon. And I always start with PCL. I think that's the most important ligament in multiligament surgery. Then I do the ACL. Then I do other intra-articular injuries. The next step would be to do the posterolateral corner and occasionally the medial ligaments. Important is to do the graft tensioning in the correct order. I always start with tensioning the PCL to restore the central pivot and tibial step off. The second step is this to fix the posterolateral corner, and I do that prior to the ACL. And the last step would be the medial structures. And this is big surgery. We can do the surgery, but as Neil also said, rehab is really important. And the modern way of thinking about rehab is that it's more criteria-based than time-based. Important is to manage range of motion, effusion, progressive weight bearing, progressive strength training, and then neuromuscular function. And we also use these dynamic PCL brace, the YAC brace, as Neil showed you. And I believe that regaining full range of motion, especially extension, very, very early is of great importance. And the rehab is very prolonged. It exceeds probably more than 12 months. Thank you very much.